Welcome everyone to the Unit 7 lecture on schizophrenia spectrum disorders. Schizophrenia literally means split mind. However, this can be confusing, and the term schizophrenia is widely misused. Some people use it to refer to multiple personality disorder, which is incorrect. The split in schizophrenia is a split from reality, and it is marked by psychosis. The split is also between emotion and thinking, rather than between personalities. Schizophrenic disorders are a spectrum of disorders marked by disturbances in thought that spill over to affect perceptual, social, and emotional processes. The prevalence is low, with only about 1% of the population suffering from these disorders. Schizophrenia itself is just one of the diagnoses on the spectrum, and it falls on the severe end of the spectrum. It is a serious chronic mental illness. Research suggests schizophrenia as a diagnosis is not distinct, but actually one of a group of disorders with similar features. The disorders on the spectrum share similar symptoms involving psychosis, a condition involving a loss of contact with or a distorted view of reality, also unusual or disorganized motor behavior, and uncommon or inappropriate behaviors affecting social interactions. Schizophrenia spectrum disorders are difficult to treat successfully when they occur alone, but when there is substance abuse as well, patients frequently get worse and do not respond to treatment. A large-scale study found the prevalence of an alcohol use disorder diagnosis in the schizophrenic population was 33% compared to 13.5% in the general population. Most believe this happens because those who experience auditory hallucinations and anxiety self-medicate, and treatment for these dual disorders is not coordinated. Most communities treat schizophrenic and substance use disorders separately. Also, once dually diagnosed, these patients receive less outpatient care, since mental health workers see them as less desirable and more difficult to treat. A main objective of this unit is to familiarize you with the symptoms of the schizophrenia spectrum disorders, which fall into four categories: positive symptoms, cognitive symptoms, psychomotor abnormalities, and negative symptoms. Starting with the positive symptoms, think of the positive symptoms as adding something that shouldn't be there or something that normally wouldn't be there. Positive symptoms include delusions, hallucinations, disordered thinking, incoherent communication, and bizarre behavior. On the spectrum, these symptoms range in severity and may persist or fluctuate. There can also be poor insight, which refers to an inability to recognize these symptoms as abnormal. The DSM-5 uses a fancy term, a fancy clinical term, anosognosia, to refer to this lack of insight. The problem with lack of insight is there is poor reality testing, and there is a split from reality. Psychotic symptoms are so real to the patient that they are not recognized as symptoms. And we'll be looking at these symptoms a little more closely. This graph shows that many individuals with schizophrenia are unaware that they have signs and symptoms of a mental illness. Most are unaware of asociality, which is little interest in social relationships. And this may be due to preoccupation with delusions and hallucinations. A psychotic episode is a very frightening and confusing experience and damages a person's sense of control and confidence. Quite simply, delusions are false personal beliefs. What makes them delusions is they are fixed. You can't use logic to talk someone out of a delusion. And I supervised many frustrated therapists who tried and tried. There are themes to the delusions that are being expressed. The text provides good explanations of each of these themes. Delusions of grandeur are common, like believing one is someone famous or powerful. I remember a client thinking he worked for the FBI, and he believed he received special messages from the president through his watch. Paranoid ideation is also a concern. For example, a helicopter may fly past overhead, and the person may believe they're being spied upon. This extreme suspiciousness about the motives of others often is connected to thinking others are plotting against them. These persecutory delusions may be beliefs that others are out to harm them. Hallucinations are perceptions of non-existent or absent stimuli, and they involve the senses. Auditory, which is the most common type of hallucination. People may hear male or female voices, which may be innocuous or threatening. The voices may give commands to hurt oneself or others. Other senses that can be involved in hallucinations are visual, olfactory, tactile, and gustatory. I recall a client who smelled gasoline, and this led to paranoid ideation that someone was trying to burn down his house. Uh, these hallucinatory experiences are very real to the person. Remember, our senses operate by transmitting nerve impulses to the brain, and certain regions of the brain will interpret this information to tell us what is in our environment. Now, because the brain regions are not working properly in schizophrenia or are internally activated, a person may actually see things that are not there. Individuals then respond to this internal stimuli as if it were real. Now, you may have seen people talking to or even arguing with the voices in their head. The second category of symptoms in schizophrenia spectrum disorders are cognitive. Cognitive symptoms appear as disorganized thinking, communication, and speech, and are common characteristics of schizophrenia. They may become apparent in speech through something called word salad, where there is a random mixture of words and phrases. For example, someone might say, "Colorless green ideas sleep furiously." Speech can obviously become quite confusing. There may also be loosening of associations, also called cognitive slippage. This is a continual shifting from topic to topic without apparent logical or meaningful connection between thoughts. Cognitive symptoms are often present before the first psychotic episode, and they tend to persist even with treatment. The third category of symptoms of schizophrenia spectrum disorders include grossly disorganized or abnormal psychomotor behavior. This refers to body movements or posture. Catatonia can be either excited or withdrawn and represents extremes in activity level. Excited catatonia can be agitation or very hyperactive behavior. On the other hand, catatonia can be withdrawn. Individuals may be totally unresponsive and hold strange positions for long periods of time. The fourth category of symptoms include negative symptoms, a decreased ability to initiate actions or speech, express emotions, or feel pleasure. These are symptoms that take away something, and there are some clinical terms that are used for these. Avolition, the inability to take action or become goal-oriented. Alogia, a lack of meaningful speech. Asociality, minimal interest in social relationships. And anhedonia, a reduced ability to experience pleasure. Anhedonia is also a symptom and a term used to describe a symptom of depression. Mental health professionals use these terms in assessments and progress notes, so they are important to remember. Another negative symptom is diminished emotional expression. This is also called restricted affect or flattened affect. Approximately 15 to 25% of individuals with schizophrenia display primarily negative symptoms. According to the DSM-5, a diagnosis of schizophrenia requires at least two of the following symptoms: delusions, hallucinations, disorganized speech, gross motor disturbance, negative symptoms. Now, at least one of the two indicators must be delusions, hallucinations, or disorganized speech. Also, there must be evidence of a deterioration from a previous level of functioning. The symptoms for schizophrenia as a diagnosis must be present most of the time for at least a month, and the disturbance must persist for at least 6 months. If we can take a broader perspective for just a moment, schizophrenia is as much a social problem as it is a psychological one. Consider the financial costs of hospitalization, treatment, and loss of productivity, estimated at $62.7 billion annually. The newer antipsychotic medications are quite expensive. There is a lifetime prevalence rate in the United States of 1.1%. And the revolution in antipsychotic medication has helped people to function well enough to be discharged quickly. The problem is that adequate support for these folks is not available. A frequent consequence is the revolving door syndrome of treatment and relapse. Schizophrenia has been observed and described as occurring in phases. Sudden onset can occur, but in most cases it starts with a prodromal phase. There is a gradual onset and buildup of symptoms, such as social withdrawal and isolation, inappropriate affect, such as laughing at a sad story or laughing at a funeral. Poor communication patterns begin occurring, and there is obvious neglect of personal grooming and hygiene. In the active phase, symptoms are prominent and there are full-blown symptoms. In the residual phase, symptom severity declines and the presentation may look like it did in the prodromal phase. There is less impairment, but complete recovery from schizophrenia is rare. Schizophrenia usually emerges during adolescence or early adulthood, and its course is variable with three likely outcomes. Patients with milder versions who experience a full recovery, patients who experience a partial recovery and who are in and out of treatment facilities, and patients whose symptoms are persistent and severe and who require permanent hospitalization. Some patients have a more favorable prognosis, and research has shown us that certain conditions are associated with a more positive outcome. These include having a sudden onset of the disorder, experiencing onset at a later age, and being well adjusted prior to the onset of symptoms. Now, this one is a bit counterintuitive, but a better prognosis is associated with a low proportion of negative symptoms. One would think that it is the positive symptoms that are more difficult to control. Other conditions include not having a loss of cognitive function, showing good adherence to treatment, being married, and this one is associated to that one, having a relatively healthy, supportive family environment to return home to. The outlook for individuals diagnosed with schizophrenia is brightening. Improvements in psychotherapy and medication have led to increased optimism regarding the course of this disorder. Some follow-up studies provide reasons for this optimism. Data showed us that after 10 years, a majority improved over time, and a minority deteriorated. A 15-year study showed 40% had periods of substantial recovery, and a sizable minority were not on any medication. There is a new perspective provided through the recovery model, which focuses on the possibility of getting better and having a meaningful life. Now, like the other mental disorders we've already studied, the etiology of schizophrenia is best understood using the multipath model. This understanding emerges through the integration of heredity, psychological characteristics, cognitive processes, and social adversities. Each dimension interacts with the others. In this lecture, I'll focus on the biological and social dimensions. The biological dimension has focused on genetics and heredity as playing an important role. We now understand that there are interactions among a large number of different genes rather than just a specific gene underlying etiology. Also, we know that closer blood relatives have a greater risk of developing the disorder. The lifetime risk or concordance rate of developing schizophrenia is strongly correlated with the degree of genetic influence. This chart showing concordance rates is based on pooled data from 40 studies. Although environment also plays a role, this data suggests there must be a genetic vulnerability to this disorder. You can see the lifetime risk is higher for identical twins than for fraternal twins, and risk decreases as genetic relatedness decreases. Even with 100% genetic relatedness, the concordance rate is less than 50%. It's not 100%, indicating that environment plays an important role. Researchers are moving away from concordance rates and focusing now on the genes responsible for the characteristics or specific traits that show up in this disorder. So they are identifying something called endophenotypes, which exist in a person before the onset of the disorder. They've identified some possible endophenotypes, which include irregularities in working memory, executive function, sustained attention, and verbal memory. These measurable heritable traits are clues to the genetics underlying this disorder. Schizophrenia is heritable, and endophenotypes may shed a light on the hidden genetic mechanisms of this disorder. Scientists are also looking at neurostructures for clues about the etiology of schizophrenia. What they have found is individuals with schizophrenia have decreased volume in the cortex and ventricle enlargements. They've also found rapid loss of brain cells over a 6-year period in young people with schizophrenia. This was found by Paul Thompson of UCLA Medical Center. He's now at USC in a longitudinal study. And Thompson called this rapid loss of brain cells a forest fire in the brain. Researchers have also found ineffective communication between different brain regions, which may lead to the cognitive, negative, and positive symptoms. I just want to talk a little bit more about a particular structural abnormality in the brain. CT and MRI brain imaging scans have shown that patients with schizophrenia have enlarged brain ventricles. Ventricles are simply cavities in the brain filled with cerebrospinal fluid, and they are an important communication network, and they produce cerebrospinal fluid. It is unclear, however, whether this abnormality is the cause or the result of this disorder. Now, this is an actual MRI scan of the brains of twins, one of whom has schizophrenia and one who does not. It clearly shows the enlarged ventricles, which are thought to be a causal factor in schizophrenia. Research on biochemical influences provides some interesting clues as to the etiology of schizophrenia. In the biological dimension, the dopamine hypothesis has been supported. This hypothesis states that schizophrenia may result from excess or too much dopamine activity in certain areas of the brain. And 3 types of drugs have supported this idea. Phenothiazines block dopamine receptor sites and reduce symptoms. L-DOPA, which is used to treat Parkinson's disease and increases dopamine levels, sometimes produces schizophrenic-like symptoms. And amphetamines increase dopamine availability and produce symptoms similar to acute paranoid schizophrenia. A link between cannabis use and psychosis has been found. Use appears to increase the chance of developing a psychotic disorder. It is dose dependent, in other words, the higher the intake, the greater the risk of having symptoms. A meta-analysis of 35 studies showed heavy use increases the risk of psychosis by up to 200%. Several possible interpretations of this link include cannabis may produce increased dopamine levels. Individuals may use cannabis to self-medicate, and individuals predisposed to psychosis may also be predisposed to use cannabis. We're going to shift gears as we continue to look at the etiology of schizophrenia by taking a look at the social dimension of the multipath model. Certain social factors have an influence, including maltreatment during childhood, chronic bullying, relationships within the home, and something called expressed emotion, which refers to negative communication patterns among relatives of individuals with schizophrenia. There is an important relationship between expressed emotion and relapse rates in schizophrenia. Expressed emotion, or EE, is the degree to which a relative of an individual with schizophrenia displays highly critical or emotionally over-involved attitudes toward the patient. A family's EE is a good predictor of the course of a schizophrenic's illness. Patients who return to families high in EE are 3 to 4 times more likely to relapse because they add stress. As I mentioned at the beginning, the treatment of schizophrenia is quite challenging. Treatment today typically involves antipsychotic medication combined with some type of psychosocial therapy. Also, there has been a recent shift from focusing on what's wrong with the person toward building on strengths and promoting health, independence, and self-determination. The recovery model focuses on separating the person from the illness. The idea is that you are not your illness, and treatment provides hope and empowerment. Antipsychotic medications can reduce the intensity of symptoms, such as hallucinations and delusions, but dosage levels need to be monitored, and some serious side effects can occur, which we'll look at in a moment. It's important to remember the medications manage the symptoms and do not cure the disorder. When Thorazine was introduced in 1955, it began a new era in the treatment of schizophrenia. Symptoms were drastically reduced. The first generation antipsychotics, such as Thorazine and Haldol, are still used and are still effective treatments, and they work by reducing dopamine levels. Newer antipsychotics, called atypical antipsychotics, such as Risperdal, Seroquel, and Zyprexa, act on both dopamine and serotonin. The atypical antipsychotics are said to have fewer side effects. These newer antipsychotics are 10 times more expensive than the older ones, and there is a lack of evidence that the newer ones are any more effective than the older ones. Quite interestingly, there are ongoing concerns over medication effectiveness. Research has shown a relatively large group of people with schizophrenia do not benefit at all from antipsychotic medication. Of course, medication compliance could be an issue here. And between 50 and 75% of patients discontinue use of antipsychotics for various reasons, including side effects. Some do not believe they need antipsychotics, and some simply mistrust the physician. Medications are discontinued sometimes even by the prescribing physician due to side effects. Every medication has side effects, and there is always a need to consider the risks versus the benefits. Some side effects can be permanent, remaining even after the medication is stopped, so close monitoring is needed. Some side effects are called extrapyramidal symptoms, and they include Parkinsonism, which is muscle tremors, shakiness, and immobility. Dystonia, involuntary muscle contractions in limbs and in the tongue. And akathisia, which is motor restlessness. This restlessness can be quite dramatic. I recall having a session with a client who paced in the office during the entire time. Some other side effects of antipsychotic medication include tardive dyskinesia, which is observed as involuntary and rhythmic tongue movement. The tongue darts in and out of the mouth. Now, this is a chronic condition. There can also be lip smacking and some other facial movements. The best treatment for schizophrenia today is a combination of antipsychotic medication and psychosocial therapy, which provides milieu therapy, where the treatment setting works like a small community, and each person has responsibilities in the therapeutic community and can help make decisions about what goes on in the program. This can empower individuals and promote recovery. There are day hospital programs called partial hospitalization programs where individuals attend group therapy, see a psychiatrist, psychiatric nurse, and a therapist, and then go home at night. And they may attend the program anywhere from 1 to 5 days a week. The group therapy can provide psychosocial skills training, increasing appropriate self-care, conversational skills, and job skills. And undesirable behaviors are decreased through reinforcement and modeling techniques. Also, community homes can assist in transition from inpatient programs to community living. This chapter concludes by taking a look at some other schizophrenia spectrum disorders, such as brief psychotic disorder, schizophreniform disorder, and schizoaffective disorder. Be familiar with the basic differences between these disorders. In particular, note that brief psychotic disorder lasts at least 1 day but less than 1 month. Schizophreniform disorder lasts between 1 month and 6 months. Brief psychotic disorder and schizophreniform are often provisional diagnoses and may change to schizophrenia if the symptoms last longer than 6 months. Schizoaffective disorder is rather rare and involves features of both schizophrenia and a major depressive or manic episode, as seen in major depression or bipolar disorder. Research is showing that newer interventions, including a combination of medications, psychotherapy, family counseling, and social skills training, have created reason for hope and optimism about recovery from schizophrenia. I'm going to leave you with a piece of schizophrenia inspired artwork from David Marsh.